be discussing about cardiac output monitoring devices. It can be shown as an OSCE. So where they may ask what is the mechanism, what are the indications, what are the limitations. So what are the indications of the cardiac output monitoring? Whenever there is a deranged cardiac function, goal-directed resuscitation of complex multifactorial shock states, in cases of continuous monitoring following cardiac and non-cardiac surgery for high-risk patients or abdominal surgeries, and for protocol-driven management of hemodynamically unstable patients. So these are the common indications of cardiac output monitoring. Cardiac output monitoring devices can be classified based on two ways. Number one, based on the principles using which the devices function. And number two, based on invasiveness. The first one is the fixed principle, which is defined as the total uptake of a substance by the peripheral tissue is equal to the product of the blood flow to the peripheral tissues and the arterial venous concentration difference of the substance. Okay, so this fixed principle forms the foundation of all the cardiac output monitoring devices, where this fixed principle is modified as a Stewart-Hamilton equation, area under the curve dilution techniques. The second method is the arterial waveform analysis technique. The third principle is the transthoracic impedance and bioreactance. The fourth principle is the Doppler principle, which is used by transthoracic echo and transesophageal echo. And the fifth principle is the indicator dilution techniques, like as used in pulse dye densitometry and lithium dilution technique. So based on the invasiveness, the cardiac output monitoring devices can be divided into three. One is invasive, minimally invasive, and non-invasive. So what is the invasive one? We all know it is the pulmonary arterial catheter, which can be used intermittently or continuously to measure the cardiac output. And it is considered to be the gold standard for cardiac output measurement, right? And minimally invasive, we have two techniques. One is pulse wave analysis and Doppler transesophageal echo. In pulse wave analysis, there could be calibrated and uncalibrated devices, where to calibrate ones are Pico plus, Litco plus, volume view, which also uses transpulmonary thermodilution, and uncalibrated ones are FlowTrack and Litco, which mainly uses the pulse wave analysis. And the non-invasive ones are bioimpedance, bioreactance. Now, what is calibration? The calibration is something every monitoring device has to undergo to eliminate or reduce bias in continuous measurements. Okay, so it mainly measures the precision and accuracy. So what is precision? When you measure repeatedly, it should show the same results. And what is accuracy? It is when you measure a value, it should be close to the actual true value, which is obtained as a gold standard. So in the hemodynamic monitoring device, the calibration ensures the measured value like cardiac output, blood pressure, vascular resistance reflect the true physiological conditions. So basically, the goal of the calibration is to align the device readings with the gold standard or reference value, ensuring that the values match the actual physiological condition, and it is not being biased by the machine's environmental sensor conditions, or because of wear and tear of the device itself, or because of the varying physiological conditions. Calibration can be external calibration or internal calibration. So what is external calibration? You use some technique to measure a standard cardiac output value. Okay, for example, in pulmonary artery catheter, you use thermodilution technique. In Pico volume view, you use transpulmonary thermodilution technique, lithium dilution technique. You are using a technique to measure a standard cardiac output value, and then you serially measure and adjust according to the baseline calibration. Okay, that is called external calibration, where it is more accurate, but it requires intermittent recalibration. Okay, it always requires either an arterial or a venous catheter, and the common devices which come under this category are Pico, Litco plus, volume view, and pulmonary artery catheter. All of that comes to calibrate externally. Whereas internal calibration, where it uses a self-adjusting algorithm based on the patient's age, gender, and the physiological conditions, arterial compliance, it makes own self-adjusting algorithms. It is less invasive but may drift over time. Some of the devices which uses this internal calibration are FlowTrack, Litco Rapid, and NICOM. Those are the bioimpedance, bioreactance devices that are used to measure cardiac output non-invasively. So a non-calibrated technique is something which reduces the bias by implementing correction factors that are pre-programmed in the monitoring device. So the nomogram scaling factor based on the patient's demographics like age, gender, height, weight, or an equation correction factor based on certain measurement character. Pulmonary artery catheter, which can be inserted through right IJV or a subclavian vein, and rarely sometimes through femoral vein also. So it is usually a 60 to 110 centimeter long catheter with 4 to 8 French caliber. Pulmonary artery catheter, It is a 60 to 110 centimeter long catheter, which can range between 4 to 8 French in caliber. And the catheter is made of polyvinyl chloride that is pliable at room temperature and softens at body temperature. And it is marked at 10 centimeter intervals. That is how you identify the pulmonary artery catheter. Okay. The main indications to use pulmonary artery catheter is because it is a gold standard for measuring the cardiac output. And we can also use it for central temperature monitoring, pulmonary artery pressure, right side of the heart pressure, and the measurement of mixed venous saturations can also be measured using pulmonary artery catheter. So if you see the pulmonary artery catheter, there is a distal yellow port, which is the main pulmonary artery pressure transducer port, where it is used for sampling of the mixed venous oxygen saturation. And the second one is the blue port, which opens at 30 centimeter proximal from the tip. Monitoring of the central venous pressure, fluid and drug administration happens through this port. Okay. And the third lumen, which is the red colored one, which leads to a balloon near the tip with a locking port, and it is used for inflation and deflation of the balloon during insertion. The fourth lumen houses wires for the thermistors to check the temperature of the injectate and measure the thermodilution for cardiac output monitoring. Okay. Fifth port can be seen, may not be seen in some of the pulmonary artery catheters. It is mainly a right ventricular infusion port, and it can also be used phasing also. So when you see this graph, when you insert the pulmonary artery catheter, you can see various waveforms when it passes through various chambers of the heart, right? When it enters from IJV to right atrium, you can see the right atrial pressure curves, that is the ACV curves. And when it enters the right ventricle, you can see a systolic curve, but no diastolic curve, like 0 to 3 millimeter mercury diastolic pressure. And when it enters the pulmonary artery, you can see the diastolic pressure going up to 8 to 15 millimeter mercury. And once it reaches the West zone 3 and you actually wedge the pulmonary artery catheter, the waveforms will be A and B waves, where the pressure reflecting would be 8 to 12 millimeter mercury. Okay. And it should always be positioned in the zone 3 of the lung, where the pulmonary arterial pressure is more than the pulmonary venous pressure. And there could be an X-ray OSCE showing this pulmonary artery catheter, where how will you know it is at the right level? It should always be below the level of the left atrium, within 2 centimeters of the cardiac ciliary. And when you aspirate the blood from the tip of the catheter, it should show values similar to the arterial blood gas value. So as I told you, the cardiac output is evaluated using a thermodilution technique, using a modified Stewart-Hamilton equation. So when after a predetermined amount of cold saline is injected into the proximal port of the PAC, thermal variations of the blood is measured. And the cardiac output and other indices are derived then using thermodilution curve generated using calculations based on the Stewart-Hamilton equation. So this is the picture showing the thermodilution, where you inject through the IJV, and then you measure the cold saline at the pulmonary artery near the West zone 3, where it is wedged. And you can see this type of curves will be formed, the thermodilution curves will be formed. If you see a narrow curve, that means the cardiac output is good. So the area under the curve is inversely proportional to the cardiac output, meaning it takes lesser time to travel through the pulmonary vessel. If the area under the curve is more, that means the cardiac output is low, means it takes a longer time to travel through the pulmonary vessel. Okay, 3 such readings are taken and then averaged and considered to be the calibrated cardiac output value. Okay, what are the factors that could affect the pulmonary artery catheter measurement? Presence of any intracardiac shunts, tricuspid regurgitation, pulmonary regurgitation, or respiratory cycle variations, and speed of the injection of the saline can all alter the pulmonary artery catheter measurements. So what are we going to directly measure from the pulmonary artery? Right atrial pressure, central venous pressure, right ventricular pressure, pulmonary artery pressure, pulmonary artery wedge pressure, and then mixed venous oxygen saturation, and also cardiac output using thermodilution technique. So these are the direct measurements that we are going to get from the pulmonary artery catheter. And you should also know the normal value. The right atrial pressure value ranges between 2 to 6 millimeter mercury. Right ventricular pressure value, systolic is around 15 to 30 millimeter mercury. Diastolic is around 3 to 8 millimeter mercury. And the pulmonary artery pressure per se will be same as the right ventricular pressure, systolic pressure, and diastolic pressure will be higher than the right ventricle, that is between 8 to 15 millimeter mercury, and the mean pulmonary artery pressure is usually between 9 to 18 millimeter mercury. The pulmonary artery wedge pressure is between 6 to 12 millimeter mercury. The mixed venous oxygen saturation, which measures the global oxygen delivery versus consumption, the normal value is usually between 60 to 80%. And the thermodilution cardiac output using Stewart-Hamilton method, the normal value is between 4 to 8 liters per minute. What are the derived parameters which we are going to get from the pulmonary artery catheter? We can get cardiac index, systemic vascular resistance, pulmonary vascular resistance, stroke volume index, oxygen delivery, and oxygen extraction ratio. Okay, the normal value of the cardiac index is 2.5 to 4 liters per minute per meter square. Coming on to systemic vascular resistance, it is between 800 to 1200 dynes per centimeter. Pulmonary vascular resistance ranges between 100 to 250 dynes per centimeter. Stroke volume measures between 60 to 100 ml per beat. Stroke volume index is between 33 to 47 ml per beat per meter square. Oxygen delivery is between 900 to 1100 ml per minute. And oxygen extraction ratio is usually between 20 to 30%. How the pulmonary artery catheter can be used for continuous monitoring, where there is a copper thermal filament which is embedded 30 centimeter proximal to the tip such that it is approximately in the right ventricle. It heats blood in the right ventricle, which is detected by the thermistor at the catheter tip, and the change in the temperature over time is computed and cardiac output is measured. And the cardiac output values are updated every 30 to 60 seconds, and average value is displayed. So, what are the complications that could happen during insertion? Arrhythmias, right bundle branch block, complete heart block, catheter misplacement, knotting, vessel or valve rupture. And complications due to catheter, which is common for all the catheters, like infection, thromboembolism, pulmonary infarction, pulmonary artery rupture. And there could be misinterpretation of data because of improper leveling and zeroing, improper location of the tip other than the zone 3, and overestimation or underestimation due to improper filling of the balloon. So what is the evidence for the use of pulmonary artery catheter? There was one trial called Pacman trial, where it was a randomized controlled trial, where they found no clear evidence of benefit or harm by managing critically ill patients with a pulmonary artery catheter. ESCAPE study, which was an evaluation of study of congestive heart failure and pulmonary artery catheterization, where they found no superiority in terms of decreasing mortality or length of the hospital stay in patients hospitalized with severe symptomatic and recurrent heart failure. Coming on to ARDS, in ARDS FACT trial, where they used pulmonary artery catheter versus central venous pressure and liberal versus conservative fluid management in patients with ARDS, where pulmonary artery catheter did not confer any benefit when it came to fluid management in ARDS. So overall, there is no benefit in critically ill patients. There is no major benefit in cardiac failure patients. There is no major benefit with ARDS patients also. Coming on to the minimally invasive techniques. So as we discussed, there were only two mechanisms under minimally invasive. One is esophageal echo, which was discussed in the ultrasound class, and second is the pulse contour analysis. So let us first see the mechanism of pulse contour analysis plus transpulmonary thermodilution technique as a calibrated method. So what is the device which commonly uses both the techniques to evaluate cardiac output? Pico, volume view, and LiCO Plus. Okay, what monitor is this? This is the volume view monitor, where you can see using transpulmonary thermodilution technique, it measures the global end diastolic index, most of the cardiac output hemodynamic values. Okay, and this is a picture showing Pico Plus, which also uses transpulmonary thermodilution and pulse contour analysis. So let us discuss quickly in brief. So, what is the mechanism of Pico and volume view? It mainly uses transpulmonary thermodilution and pulse wave analysis as the underlying mechanism, where calibration is done using the transpulmonary thermodilution technique. Intermittently, a cold injectate is used to derive the cardiac output. So, cold saline is injected into the central venous catheter, and there will be an arterial cannula which is placed in the major artery like femoral, axillary, or brachial artery, which has an integrated thermistor. So when you inject this cold injectate, this thermistor will sense and it will create a thermodilution curve, okay, across the pulmonary vessels to the femoral vessels, right? That is why it is called transpulmonary thermodilution. When the transpulmonary thermodilution curve comes, it applies the same modified Stewart-Hamilton equation to find out the cardiac output, okay? And it also utilizes the pulse contour analysis for the continuous waveform analysis and continuous cardiac output monitoring. The main limitations are the arterial compliance may be a major limitation factor because it could be non-linear and it changes with age and it varies between individuals. And usually cannulation through the femoral vein should be avoided because it can cause the overestimation of the intrathoracic blood volume. If suppose you decide femoral vein is the site for the central venous catheterization, then do it in two different limbs. If you're putting the central venous catheter on the right side, put the arterial catheter on the left side so that the crosstalk phenomenon will be avoided. So compared to the pulmonary artery catheter, the additional values that you're gonna get with PICO and volume view is that global end diastolic volume, intrathoracic blood volume, extravascular lung water, and pulmonary vascular permeability index, which may be used to differentiate many things, whether it's a cardiogenic pulmonary edema or it's a ARDS, using these values. So if you see the parts of the volume view, there will be a femoral catheter which will be attached to this sensor. This femoral catheter is an arterial catheter, and there is also a thermistor manifold which will be attached to the central venous line. So you can see this is the central venous line which is attached to the thermistor manifold. So when you inject the cold injectate, it goes through this cannula, and then there is a femoral artery catheter which is attached to the sensor. So this cold injectate travels through the heart and then it comes to the femoral artery, and then this is being sensed by the sensor, and the thermodilution curve comes, and there will be a simultaneous calibration using the transpulmonary thermodilution technique, and there is a continuous cardiac output monitoring because of the pulse contour analysis technique. Okay, in the same way the PICO also functions. So what are the measurements we are going to get from the PICO and the volume view? Cardiac output, cardiac index, stroke volume, systemic vascular resistance index. Along with all of that, we are going to get extravascular lung water, where the normal value is between 3 to 7 ml per kg, pulmonary vascular permeability index, where the normal value is between 1 to 3, and global end diastolic volume, which ranges between 680 to 800 ml per meter square, and global ejection fraction, which measures between 25 to 35%. Errors, there could be indicator recirculation, indicator loss into the lungs in patients with pulmonary edema, or errors due to arrhythmias, respiratory variation can happen, presence of intracardiac, intrapulmonary shunt can lead to variations of the cardiac output measurements, and valvular regurgitation can alter the cardiac output monitoring. Coming on to pulse power analysis, that is LITCO plus or LITCO TM. So this is the picture of the LITCO monitor, where you can see it uses a lithium as the thermodilution technique, as a dye dilution technique, to calibrate the system. So it uses the lithium dilution for intermittent cardiac output calibration and pulse power analysis for the continuous cardiac output monitoring. It functions using the mechanism of conservation of mass and energy. And similarly, when you give lithium, there will be a thermodilution curve which will be formed, and using Stewart-Hamilton equation, the cardiac output value will be calculated. And for continuous waveform cardiac output monitoring, it uses the pulse power analysis. The effect of the waveform artifacts are minimal, and it is less affected by the damping due to the time-based autocorrelation approach. Okay, it is minimally invasive. It requires arterial and venous access. So as I told you, it uses the lithium dilution as the calibration technique. So intermittently, the lithium is being injected. 0.5 to 2 ml boluses of lithium chloride is injected through a central venous catheter, and then this is sensed by an arterial cannula where the sensor is attached and the thermodilution curve forms. So using the area under the curve and the Stewart-Hamilton equation, the calibration will be done. And using pulse power analysis, there will be a continuous cardiac output monitoring. Coming on to LITCO Rapid. So it has the same name. It doesn't function in the same way as LITCO Plus. Okay. So it just has the same name because it uses the conservation of energy, but not mass. Okay. It applies the Wien-Kessel model of the arterial compliance, where the shape and the area under the arterial pressure waveform will provide the information about stroke volume. It just does pulse contour analysis. It is not like the LITCO Plus, which uses the lithium dilution to calibrate and pulse power to continuously monitor cardiac output. It is just a LITCO technique which uses the pulse contour to measure the cardiac output. So this is a non-calibrated system where we are not using lithium to calibrate, and based on the nomograms and the patient-specific adjustments, it gets auto-calibrated. Okay, so it is a very minimally invasive technique where it requires only an arterial catheter. Okay, coming on to the next minimally invasive technique, which is uncalibrated, is the pulse pressure analysis, which is used by FlowTrack. Basically, the FlowTrack is the arterial line sensor which we attach to the arterial line, and Vigilio is the processing and the display monitor which we see. So this is the FlowTrack and the Vigilio monitor. Here, pulse pressure analysis is the basic mechanism where the system samples the arterial pressure waveform at 100 Hz over 20-second intervals, generating 2000 data points. So the FlowTrack and Vigilio, basically it is an arterial pressure-based cardiac output monitoring technology that estimates stroke volume and cardiac output using arterial waveform analysis. Here also the mechanism is conservation of energy and dynamic arterial compliance model. Okay, it is also internally calibrated and it adjusts according to the vascular tone. Okay, there is no need for manual calibration. It doesn't need an indicator. It uses only a peripheral arterial line. It can be used for continuous cardiac output monitoring. It can be used even in patients with arrhythmias and spontaneously breathing conditions, and it allows trending of the cardiac output changes over time. But it is less accurate in extreme vasodilatation, and it is affected by arterial waveform damping, and absolute cardiac output values may be less reliable in aortic regurgitation and shock states. If you see this table, so we saw fixed principle is the baseline principle, gold standard principle used in all the techniques with some variations as Stewart-Hamilton equation. Now, pulmonary artery catheter is being considered to be the gold standard for cardiac output monitoring. But the evidence, there is no major use with the pulmonary artery catheter, such an invasive technique which has a lot of complications, and the evidence is very poor. Though it is well validated and taken as a gold standard one. Okay, then comes the PICO and the volume view, which is a minimally invasive one where you need a central catheter and arterial catheter, and you keep calibrating the cardiac output using any one of the techniques like cold injectate or lithium dilution. You calibrate the cardiac output value and keep it as a reference, and based on that, you measure the continuous cardiac output monitoring by means of pulse power analysis or pulse pressure analysis or a pulse wave analysis, and then you monitor the cardiac output. This is one of the non-invasive method, that is the bioimpedance and the bioreactance. So bioimpedance and bioreactance are some of the non-invasive methods of continuous cardiac output monitoring. So let us see the brief difference. Bioimpedance mainly measures the changes in the thoracic electric impedance due to the blood flow, whereas bioreactance measures the phase shifts in high frequency electrical currents across the thorax. So bioreactance is less affected by the noise and external interference, and hence it is preferred more than the impedance. Okay. In bioimpedance, the main mechanism used is that amplitude variations of the electrical signals to estimate the stroke volume. Whereas in reactance, it uses phase shifts in oscillating currents to assess the aortic blood flow volume changes. So bioreactance is more reliable in low flow states. Okay. And when it comes to signal interference, prone to motion artifacts, lung edema, and pleural effusions. Whereas bioreactance is less susceptible to interference from the lung condition. Bioreactance is a very reliable cardiac output monitor. Some of the examples of the devices are BIOS and PhysioFlow in case of bioimpedance, and Cheetah NICOM is one of the most commonly used bioreactance method. What is this device? It is the CC Nexfin ClearSight device. It's one of the non-invasive cardiac output monitoring device where it uses a volume clamp method, that is the finger cuff technology, where the system uses the infrared plethysmography to measure the finger artery diameter, and there is an inflatable bladder within the cuff, applies varying pressure to keep the artery diameter constant throughout the cardiac cycle, and this method ensures continuous non-invasive blood pressure monitoring. And along with this volume clamp method, there is the pulse contour analysis which keeps happening, where the brachial arterial pressure waveform is reconstructed from the finger BP using a transfer function, and then cardiac output is monitored using non-invasive technique. So this completes our cardiac output monitoring.